Okay. Hi everyone, I'm Dr. Shivangi and I'm your dermatology faculty at Medway. So today what we are going to do is we are going to discuss some questions that are very important when it comes to dermatology for your FMGE exams. Okay. So firstly, I'd like to give you some quick ideas about what I'm going to discuss. The questions that I'm discussing are not as important as the topics that have been asked. Questions will not be repeated, but the topics are very, very frequently repeated. So you have to make sure that you jot down these topics somewhere and you know, at the last minute just revise these topics, because very high probability that the questions will come again from these topics. Not the same questions, but the topics are important. Okay. So we'll start with our questions. With every question, try to understand that you can revise 4 topics because there are 4 options. One option will be the right answer. I will also be telling you something, little things about the other options as well. Let's start with the first question. What is the most likely diagnosis for a patient with a history of steroid? This is a very important thing that they have mentioned, that there's a history of steroid use, okay? And complaining of a lesion as shown. Let go of the history of steroid also. What do you think this is? What does it look like? It looks like annular lesion. Okay, annular is one thing that you need to remember. So, and you can make out that this is tinea. But does tinea normally look like this? No. What happens in tinea is that it is an annular lesion, but there is central clearing and there is activity at the periphery. You understand? Central clearing, activity at the periphery. Here, there is activity at the periphery, but there is no central clearing. So, this is not the typical presentation of tinea. This looks like an atypical presentation of tinea. That is because of the history of steroid use that has been given. The patient used steroids and they changed the clinical picture of the disease. Whenever the word steroid comes, the answer has to be incognito. What is incognito? Incognito mode, that is hidden. You can't make it out clearly. That is what is here. This is tinea, but it is hidden. It is not the typical presentation. It is a little atypical presentation of tinea. Okay. So the answer is tinea incognito. Why is it not tinea corporis? This would be the lesion for tinea corporis. Okay. You would have activity at the periphery and you would have clearing in the center. That is what is tinea corporis. What is tinea manum and tinea unguum? Tinea manum is on the hands and this is for the nails. So if you have a picture with nail in it and they're asking for tinea, that is tinea unguum. If you have a picture of a hand, specifically the palmar surface, and they're asking what it is tinea manum. Alright. If you have any queries, you can let me know over here. I'll be able to see it. So the answer is tinea incognito. Next question. Diagnose the skin condition based on the provided image. Chalo. Very simple. See, I'll tell you one thing in dermatology. You don't have to see a lot of what is written in the question. If an image is given and it is a clinical image, the diagnosis is straightforward. It should take you 2 to 3 seconds to just be like, this is this and move on. Okay. When you're writing an exam, which is a competitive exam, you have to make sure that the bigger subjects, dermatology is a very short subject, it's a very easy subject. Don't give it as much importance when you're solving the questions. Don't give this question 2 minutes because medicine ke questions will be left behind then. Medicine, surgery, OBGYN, peds, they're going to come with really lengthy questions. So make sure you give more importance to those questions and make sure you've developed tricks wherein you solve dermatology, orthopedics, where images are given, just solve them very, very quickly. Even if you don't know anything about it, what does it look like? It looks like a nevus. But, so basically it is like a pigmented lesion. Let's start from the basics. Pigmented lesion. Okay. But what do you see in this? There is asymmetry. Okay. It is not a very symmetrical lesion. It is an asymmetrical lesion with irregular margins. So that is asymmetry is present over here. Does it look like SCC to you? No. SCC will have rolled out margins. Does it look like benign melanoma? No. What does it look like? It looks like a malignant melanoma. Why am I saying a malignant melanoma? Because there is a B, C, D criteria for malignant melanoma. There's also E over here. A is asymmetry, which is present here. What is B? Okay, my bad, A, B, C. Okay, so A, B, C, D, E. What is B? B is the border being irregular. The border is irregular here. What is C and what is D? C is the color. Color is also not very, somewhere it is dark, somewhere it is light. What is D? D is the diameter. D is the depth. My bad. D is the depth of the lesion, which you cannot see by yourself, but as clinicians we can make out that D is the depth. Okay. So the skin lesion with the provided image, what do you think it's going to be? It is a pigmented lesion. You clearly see asymmetry present over here. So what does it look like? It looks like a malignant melanoma. Alright. SCC, again, not the normal location for SCC also. Junctional nevus. How does a junctional nevus look like? So junctional nevus is basically going to be an elevated lesion. Okay, it's not going to be, this looks like a flat lesion. Junctional nevus is going to be an elevated lesion. If you have any queries, you can let me know. I am going to be seeing all the queries here and I am going to be answering them as well. Okay. So skin condition provided by the image, you understand the basic of it. So it is a malignant melanoma. Okay. What is the condition shown in this image? Alright. See. Again, it's a image based question. It should take you 1 minute. What are these lesions? And what are the 4 options? Try to fit them over here. Does it look like a hemorrhoid to you? No. Hemorrhoid may, they will give you what? They'll give you anal canal ka picture. Okay. They'll also give you, they'll be like anal canal with something protruding out of it. That is going to be a hemorrhoid picture. Okay. What is condyloma lata? Condyloma lata is a characteristic of syphilis. Okay. What happens over here? These are moist but also flat lesions which are full of spirochetes and they are very, very infectious. Okay. Do these look like flat lesions to you? They are not. Some of them are papules, some of them are, you see this V-shaped, acuminate shaped. Yeah. So what does it look like? It is a condyloma acuminata. I hope I have told you why is it a condyloma acuminata. You should confuse between condyloma acuminata and condyloma lata because both of them are pretty much similar, but acuminata is always going to be projected out and lata is always going to be flat coin-shaped lesions. Okay, lata will be present with syphilis and acuminata, it is a normal viral infection. It is a HPV infection. Okay. Next question. If any queries, you guys can let me know. Alright, what is the likely diagnosis based on the history of drug use and the image features similar to those seen in the patient's brother? So, you need to see that there is a history of drug use over here. History of drug use, which is important. And you have an image. Alright. Chalo. Now when they say there's a history of drug use, try to rule out options. History of drug use, malaria has nothing to do with it. What is this? This is a sweat gland duct obstruction. Okay. Alright. So that is what is malaria. Can it occur on forehead? Yes, it can. But will it look like this? This looks like acne. If you look at it, it looks like acne. So malaria is a sweat gland duct obstruction. History will not say a history of drug abuse. It will rather say that the patient sweats a lot. You know, he has itchy lesions on the forehead. It is very itchy and it is sweating. The patient sweats a lot. There is a lot of sweat gland duct obstruction, as a result of which the patient comes like this. Okay, so that is your malaria. It is out of question. What is your morbilliform eruptions? And how do they look, morbilliform eruptions? So what happens over here is that they are going to be like pedicule lesions on the body, usually happening because of a viral infection. You know, that is your morbilliform eruptions. What is a fixed drug eruption and acneiform eruptions? Now, the history of drug use can go towards two things. Either it can be FDE or it can be acneiform eruptions. Okay? I'll tell you what to understand how. FDE, if they say FDE, they will show you either a picture of the lips, that is the mucocutaneous area, or they'll show you a penile picture. Okay? And what is going to be the clinical picture? This is acne. In FDE, the clinical picture is going to look like, if it is a recent FDE, it could be bullous, or it could be like a violaceous erythema is going to be there. Okay? But if it is a late picture, it's going to be just hyperpigmentation. Does it look like hyperpigmentation and a bullous lesion? No. So what is it? It looks like acne, but the acne that is happening because of drugs, so that is a acneiform eruption. I hope I've made myself clear. I'm still checking the chat. Let me know if, yeah, acneiform eruptions, you people have answered. That's really nice. Okay, great. Chalo. So the likely diagnosis with a history of drug use is acneiform eruptions. Easy question. Just understand that the questions have to be solved very, very quickly. You have to see it and you have to be like, okay, this is the answer, move on. Chalo. Now a patient presents with features shown in the image, including pain in the DIP. What is the diagnosis based on the given features? Okay. Even if you let go of, see, there'll be two category of people solving this question. The first category will be like, okay, I had read somewhere that some joint is involved in this disease, PIP was involved in some disease, DIP was involved in some disease. They'll waste their time like that. And they'll think, Bapre, yaad nahi aa raha, I don't know how will I do it. The second person will just look at the image. Okay. And they'll be like, these lesions, how do these lesions look? These are annular lesions. These are erythematous lesions. Okay. And these lesions have silvery white scaling. What am I describing here? What does it look like? And the person is itching. So you tell me, what does it look like? It looks like psoriasis. Okay. Annular lesions, they are erythematous lesions. There is silvery white scaling. And in the picture only the person is itching. It is psoriasis. Let go of PIP, let go of DIP. What will it be? What can it be? It can only be psoriatic arthritis. Saw the picture, it is psoriasis, the answer is psoriatic arthritis, move on. But still, to just, I'm here to help you in all the different ways. So this is one way of approaching the question. The other way of approaching the question is going to be the lengthier way. DIP kya tha, PIP, where was PIP, where was DIP, you try to recall all the problems that were happening. In psoriatic arthritis, the small joints are involved. Okay. The most common joint involved is DIP. What do you see? There's a characteristic lesion that you see over here. What is that lesion? The lesion is going to be pencil and cup appearance. How does it look like? This is one joint and this is the other joint. Okay. So it looks like a pencil going in a cup. What is this pencil? This is the distal phalanx. The distal part is this. And this is the proximal phalanx. Okay. So this is the pencil and cup appearance which is seen in psoriatic arthritis. Otherwise, just look at the lesion and you will be able to tell. Why not osteoarthritis, rheumatoid arthritis? Osteoarthritis, see, it involves big joints. It will be the knee, your ankle, your wrist. Similarly, rheumatoid arthritis also can involve PIP, can involve DIP, but the question and the image will not be this. They will say that the patient has some feature of, like rheumatic fever or something like that. So try to solve questions quickly and just next, okay? If any queries, you can please let me know. I'll be here to help. Now the patient is on treatment with 13-cis-retinoic acid. Okay, which of the following is one of the side effects of the drug? They're just trying to scare you with such a heavy term. What is it? It is just a simple retinol. Okay, oral retinol, that is tretinoin. What does it cause? It is a teratogenic drug. You don't give it during pregnancy because it can cause teratogenicity. Neural tube defects are seen in valproate. Okay, So it is a straightforward answer. 13-cis-retinoic acid is a teratogenic drug. Alright, next question. Where is it used? It is used in acne. Oral isotretinoin we give to the patients. Okay. Now patient presents with lesions as shown in the image. Later patient also develops arthritis. Again, what is the treatment? Now this is a question wherein you need to know the answer. Like you need to have mucked up the answer, only then you can answer it. What are the lesions? Again, these are annular lesions. There are plaques. There are erythematous. On back. What does it look like? It looks like psoriasis. It looks like psoriasis. Okay. Now, he has developed arthritis. So, the patient, they are saying that the patient has psoriatic arthritis. What is the drug of choice? The drug of choice for psoriatic arthritis is methotrexate. You need to remember this. You need to remember a couple of drug of choices in the, dermatology as a subject. There are very few that will be asked. Psoriatic arthritis has the most probability of being asked. So, the drug of choice for psoriatic arthritis is methotrexate. Okay? Next question. Okay. Now, identify the condition shown in the image below. It's, again, if you know it, you know it. If you don't know it, you can really get confused here. What do you see over here? We see grouped. Again, if I say grouped, it can be a little confusing, but these are grouped lesions. Okay? They have crusting and they look kind of orange to brown. Okay? What do you think this can be? Rule out. Molluscum contagiosum are white lesions. They are pearly, white, with umbilication. They can happen on face, that is true. Of child, that is also true. ये child का picture है and they have given lesions on the face. That is possible, but the pearly white with umbilication is not present over here. So molluscum contagiosum out. Alright. Herpes simplex. Again, you have herpes simplex HS virus 1 and 2. HSV1 is going to give you labial, basically oral herpes. HSV2 is going to give you genital herpes. Okay? So, but does it look like this? No, it does not look like this. This, that crusting, that orange color crust over here, that is not seen in herpes. Chickenpox. Chickenpox will come anywhere on the body. It will be mostly a centripetal distribution. They'll show a abdominal picture. Like abdominal picture of a child with some lesions over here, that rose petal dew appearance, all that is going to be there. What is this? This is impetigo. So if you know it, you can just be like, okay, this is impetigo. You don't even have to go through all the three options. You just have to be like, okay, impetigo, move on. I don't know for what question are you answering C. Was there an answer which was C? You guys? In the last 4 questions, C was not an answer. You guys are answering something wrong. Okay? If you're confused over here, it is not herpes simplex, it is impetigo. If you're trying to answer C for this one, it is not herpes simplex, it is impetigo. Why? Because there is grouping of the lesions. Again, grouping goes in favor of herpes simplex. There are grouped vesicles. There is no crusting, nothing over here. There is orange crusting in this picture. Okay? That is impetigo. It's a bacterial infection that happens because of staph or streptococcal and usually happens in children. Okay. Now next question. What are these lines? Okay. So, chalo. Lymphatic development, dermatomes, Blaschko lines and vascular development. These are Blaschko lines. It's a very typical picture. You have to remember this. Blaschko lines. Now, what happens is that they have different presentations in different parts of the body. Okay? On the scalp, they are going to be spiral. Alright, on the trunk, they are going to be S-shaped, and they are going to be on limbs longitudinal. Okay, so what is it? These are Blaschko lines. Alright, what are Blaschko lines? I'll just tell you a little about them also. Wait, this is confusing. Okay, limbs, this is longitudinal. So these are basically lines through which your melanocytes migrate. So these are lines of migration. During embryonic stages, when your cells were migrating, they migrated through these pathways. Okay. So these are lines of embryonic migration. There are two diseases that are associated with Blaschkoid lines. One is incognitia pigmenti, and the other disease is going to be linear verrucous epidermal nevus. Okay, so these are two diseases that are associated with Blaschkoid lines. They may ask it. Okay, which of the following manifestation is absent in individuals with congenital syphilis? Okay, again a very easy question. You can look at the terms and you will be like, oh my god, I don't know what is all of this. But genital ulcers are never present, never in congenital syphilis. Why are they never present in congenital syphilis? Genital ulcers are a manifestation of how you got the disease. Okay, so this was a sexually transmitted disease. If the disease is sexually transmitted, you will get a genital ulcer. But in a child, in a baby, the disease is not sexually transmitted. It is given from the mother to the child. So they will never have this primary lesion. They directly go to secondary syphilis. Directly to secondary syphilis. Because the syphilis has directly entered the blood. It has not formed that ulcer, nothing. So genital lesions are not there, never in congenital syphilis. It directly goes into secondary syphilis stage. Okay, you will have Higuminachi's sign, you will have Hutchinson's teeth, but you will not have genital ulcers. Please remember that. What are Hutchinson's teeth? These are peg-shaped teeth. What is the Higuminachi's sign? This is going to be, you know, your clavicle on the medial part, it becomes thickening. So thickening of the clavicle, of the basically the sternal part of your clavicle. Okay. So easy, not that difficult. Just a concept that they were trying to ask, that genital syphilis will not have, congenital syphilis will not have genital lesions. Okay. Chalo, next. What is the treatment used for vitiligo amongst the options given below? Okay. For vitiligo, what is happening in vitiligo? Vitiligo, if you know the, like the pathophysiology of vitiligo, you will be able to answer what the drug is. For vitiligo, you have autoimmunity. Okay? What happens over here is that your cells in the body, they start destroying what? Melanocytes. If your melanocytes are destroyed, you will have no melanoblasts. You will basically not have melanosomes. Melanoblasts were there. They made melanocytes. Melanocytes got destroyed. In the melanocyte, you will have small melanosomes, which are now not present. These melanosomes were going to have melanin in them. Okay? Melanin. Now this melanin is not there. So what is it? It is going to be complete depigmentation. Okay? So this was the basic problem that was happening. What happened? You had T cells, they had gone crazy. Autoimmunity, mainly T cells are going crazy. They're going to target your melanocytes. They're going to destroy the melanocytes. Melanin is gone. The skin color becomes completely white. There is depigmentation. What is a drug? What is basically the treatment of choice? It is psoralen. That is PUVA. What will PUVA do? So PUVA has various mechanisms to act. Firstly, it will by itself stimulate melanin. Okay, so melanin was getting reduced. You stimulated melanin. That is one good thing you did. The second thing was, it will kind of, inhibit your T cells. So T cells were going crazy and they were destroying your melanocytes, and melanosomes were not there, so it inhibits T cells. So now your melanocytes are also safe. Okay, so this is how PUVA by various mechanisms helps people with vitiligo. Alright. Someone is asking why no steroids. Actually, steroids are also used. So the question should have mentioned what is the extent of vitiligo. Okay, steroids is also used, but if you ask the treatment out of all of these, PUVA will be the answer. PUVA will be the right answer. Okay. If they ask which is not used, steroid can be used, PUVA can be used. If your lesions are less than 20%, you use PUVA. If they are very high, very extensive, you use steroids, systemic steroids. Okay. If the lesions are not that much, you don't give systemic steroids because it will hamper your entire immunity. It can give you so many other problems. So that way, PUVA is a better answer. Okay. Chalo. Next question. Zinc smear also shown in the image, as shown in the image shows. Okay. Now again, somebody can just look at it and be like, oh my god, I don't understand what they are showing. I'll not be able to answer. Move on. It's very simple. Let go of this. Let go of all of this. Don't look at it. Zinc smear shows what? Zinc cells. What is the other name of zinc cells? Acantholytic cells. Okay. So what will it show? It will show acantholytic cells. What are acantholytic cells? Why not acanthosis? What is acanthosis? It is increase in the thickness of spinosome layer. Okay. So zinc cells, yeah. So zinc cells, zinc smear will show zinc cells. Zinc cells are acantholytic cells. Acanthosis will not be seen over here. Alright, what are smudge cells? Smudge cells are basically when you make a peripheral smear, no? Smear, in that your lymphocytes, they actually get smudged. While making that peripheral, while moving the slide, your cells get smudged. That is a smudge cell. Coming to acantholytic cells, you have acantholysis. Chalo, let's start with acantholysis. You have primary acantholysis and you have secondary acantholysis. Okay, what is primary acantholysis and what is secondary acantholysis? What is acantholysis? Acantholysis means there is ballooning of the cells. Okay. Alright, so that is your acantholysis. What is ballooning of cells? Okay, I'll just explain that to you. Understand, suppose this is your cell. Okay, these are multiple cells that are attached to each other. And this is actually not round, it is supposed to be like this. These are your cells. Okay, I'll just rub this. Just take 2 minutes to understand the concept, it will really help you. Suppose these are your cells. Okay, so they have connections in between and everything is fine. Now, for some reason, the connections got broken. So these connections were broken. Now these connections can be broken from inside or from outside. If the connections are broken from outside, it is called as primary acantholysis. If they are broken from inside, it is called as secondary acantholysis. What is outside and what is inside? Okay. So outside you have antibodies against the desmosomes. And inside, matlab some problem was inside the cell that caused this issue. Okay. I'll just rub, make some space and continue explaining. Okay. So, when I say outside, there were antibodies against the desmosomes. So, the cells were sticking like this. There was some destruction from outside. The cells were apart and they started ballooning. They were not being pulled. They started becoming round. Okay. So, what are the causes for primary acantholysis? For primary acantholysis, think of pemphigus. Why? Because autoimmunity is there. Cells against the desmosomes, antibodies against desmosomes are present. Think of Haley-Haley. Think of Darier's. So these are the causes of primary acantholysis. What is the cause of secondary acantholysis? Something from inside the cell is causing disruption, generally herpes. It is the cause of secondary acantholysis, okay? But the answer was very simple. Zinc smear will show zinc. What will it show? Acantholytic cells, okay? Zinc cells. Simple. I hope you guys are understanding. Okay. A 30-year-old female presents with a history of fever and oral ulcers and has developed an erythematous lesion on the surface. Now, what is your diagnosis? Again, don't look at the picture. There is history of fever, that is the first thing, okay. Then there are oral ulcers, that is the second thing. Fever hua, they had ulcers. Now they have an erythematous lesion on the skin surface. What is your diagnosis? What does it point towards? Melasma will be brown in color. Rosacea, look at the nasolabial fold. It is kind of spared. This is red and this is not red. So, nasolabial fold is spared. Rosacea, the nasolabial fold will be involved. Dermatomyositis, what will be the history? They will give a history of muscle weakness. But in SLE, they will give you a history of fever. There will be oral ulcers which are aphthous ulcers, and there is going to be this malar rash that becomes worse when exposed to sun. Okay, so these three things are there, and this spares the nasolabial fold. Okay, so simple answer, the answer is SLE. The following lesion noticed in a patient with a history of involuntary weight loss. So actually this should be weight gain. Okay, this is a mistake over here. This is weight gain. What is your diagnosis? The following lesion is noticed in a patient with a history of involuntary weight gain. So there is weight gain. That is the first thing. Secondly, there is this velvety appearance on flexures, neck. It could be the axilla. Okay. What is this? This is acanthosis nigricans. Okay. Simple, acanthosis nigricans. Just look at it, answer it and move on. Alright. Why not intertriginous candida? It will not look like this, and the image that you will have is going to be either, so it will be an intertriginous area as it says, intertriginous candida. So they can give you either toe or hands or the thigh picture, and then you have to think of candida. There is going to be maceration, there is not going to be this hyperpigmented lesion, you know. So this goes directly in the favor of acanthosis. If any questions, please let me know, you guys. Okay. Incorrect regarding the displayed lesion. What is this? Let go of everything. You have to look at the picture and you have to first make the diagnosis. What does it look like? Read the lesion. It has grouped vesicles. Okay. What does it have? It has erythema, and the distribution is what? It is dermatomal. Okay. And it is a unilateral lesion. एक ही side का picture दिया, it is a unilateral lesion with grouped vesicles and erythema. Alright. So what does it look like? It looks like herpes zoster. Okay. Which is basically a reactivation of varicella. First you have chickenpox, it goes and stays dormant, and then in the ganglia, and then after some time, after some years, if there's old age, if there's, you know, loss of immunity or something, it gets reactivated. And the reactivation looks like a herpes zoster, and this is the herpes zoster lesion, a very characteristic lesion. Now incorrect, you want to know. The lesions are infectious to a seronegative individual. Try to understand what they are saying. Seronegative individual matlab individual who has never had chickenpox or varicella before. Are they infectious? Yes. So suppose if a mother has herpes zoster and the child has not had chickenpox, she will give the child chickenpox. Okay, she will not give the child herpes zoster because the primary lesion always has to be, the primary infection has to be chickenpox. After that, when it gets reactivated, then you will have herpes zoster. But the primary infection is chickenpox. So it is infectious to a seronegative individual. Yes, that is true. They want incorrect. Can be associated with meningoencephalitis. Yes, it is a rare complication. It is there. Bilaterally symmetrical dermatomal distribution. Bilaterally symmetrical is not true. Dermatomal, yes. Vesicular eruption, yes. But bilaterally symmetrical makes this answer incorrect. Okay, and geniculate ganglia is involved in Ramsay-Hunt syndrome, that is also true. Herpes zoster, you need to know two things. Two different parts can be involved. There is ophthalmicus and there is oticus. Okay, and this oticus is because of geniculate ganglia involvement. Alright, this is the basic about herpes zoster. Chalo, next. Again, you just have to look at the picture, you cannot get it wrong. These are going to be the questions that will decide you pass or fail, or that will decide you getting selected or not getting selected if they come in NEET-PG. What is this? This is Humbee's knife. Just you need to know this. Single cutting razor, double cutting razor, they've just randomly made names. This is just Humbee's knife. There are very few instruments in dermatology, but you need to know them. Those very few have to be known. Okay, this is Humbee's knife. What is it used for? It is used for skin grafting. What is the most suitable approach to minimize the likelihood of keloid? Okay. Alright, so what happens in keloid? Basically, there was a scar, there was an injury. Okay. Post injury, the body tries to heal it, forms a scar using collagen. Now, when the body produces a lot of collagen, it leads to formation of a keloid. There's a keloidal tendency, not everybody gets it, but some people who have a keloidal tendency will develop keloids. Okay. What do you do to decrease the chances of person developing a keloid is going to be intralesional steroids. Why? Because it reduces inflammation and it also reduces excessive collagen deposition. So the collagen also reduces, as a result of which your scar is not that elevated. It is a flat scar, does not look like a keloid. Why is surgery not the answer? Suppose this was a keloid. Okay, this was the surrounding skin and this was the keloid. Now you decide to cut it out. You took this out. So now you have a surrounding skin and you have a new gap here. Okay. What is going to happen? Again, this is a scar. Like this is an injury and the body is going to heal with scar formation. Again, a keloid will be formed. So this will not help. Surgery will give you another keloid. What you have to do is you have to give ILS. That is the treatment of choice. Now, what will be the diagnosis of an infant? This is an infant exhibiting the following condition after a pharyngeal infection. Okay. It is again a very simple question. Pharyngeal infection. The answer is it was caused by staph mostly. And after a pharyngeal infection, if an infant, suddenly there's peeling of the skin. What do you see here? You see skin peeling. Okay? Skin peeling is present. So what does it become? It becomes staphylococcal scalded skin syndrome. It looks like a scalded skin. Why not EBS? EBS usually happens in trauma prone areas. Okay? It will not happen on the whole body. It will only happen in trauma prone areas. And they will not give a history of pharyngeal infection. If they have a history of pharyngeal infection, this is staphylococcal scalded skin syndrome. Okay? Impetigo we have already seen. Usually it is seen around the lips, around nose. They're going to have crusted lesions. Okay? Why not pemphigus foliaceus? Again, pemphigus foliaceus are going to be very superficial blisters which don't actually present as blisters ever. What does it come with? It comes with just erosions. But this is not the clinical picture. If they say pharyngeal infection, pemphigus foliaceus is again an autoimmune disorder. So if they say pharyngeal infection, you think of staphylococcal scalded skin syndrome. Next, identify the penile lesions shown below. What are these? What do you see over here? These are just round lesions, looks like papules. Simple, very simple, this is a pearly penile papule. What are these? Asymptomatic lesions. Okay, so these are pearly penile papules. Alright. Genital warts we have just seen. They're going to have finger-like projections. They're going to have, you know, like finger-like projections are going to be there. These are papules with no projections. They're just very round, very even. These are pearly penile papules. Alright. Now, we have already discussed this before also. The lesion shows below shows the characteristic of. What do you, just look at the lesion. What is it? It is a papule with umbilication. Okay, so it is a papule with central umbilication. What does it look like? It looks like molluscum contagiosum. Common warts we have seen. Pemphigus is either going to be a erosion or it's going to be a bulla. Chicken pox is going to have a rose petal on dewdrop appearance. Okay, this is central umbilication. This is the umbilication I'm talking about. This part, this is umbilicated. Okay, and this is a papule with central umbilication, molluscum contagiosum. Okay, 15-year-old girl presents with itchy lesions on her arms as shown. Her family history is positive for asthma. Which of the following is a probable diagnosis? Firstly, there are itchy lesions. Secondly, there is a family history of asthma. Okay, what is the probable diagnosis? Okay, so you try to understand, this is a very simple question. This is what part of her body? This is the flexural part of elbow, like the, okay. What do you see over here? You look at these things. What are these? I'll erase it for you to see that better. These are increased skin markings. Okay, so flexures with increased skin markings. So increased skin markings goes in the favor of what? Lichenification. Okay, so if you have lichenification in the flexures with the family history positive for asthma, that is history positive for atopy. So what is this? What is the child going to have? The child is going to have atopic dermatitis. I'll tell you again why is it atopic dermatitis. Firstly, flexures are involved in a child. Think of atopic dermatitis. Anybody in the family having a history of asthma or any other allergy, atopic dermatitis. These are the things that have to point towards atopic dermatitis. Seborrheic dermatitis will have presentation in seborrheic areas. It will be your scalp, your eyebrows, nasolabial fold, back, interscapular area, you know. So not seborrheic dermatitis picture. Allergic contact dermatitis. Now this is a very important thing I would want you to know, that if it is an allergic contact dermatitis, it is an acute situation. Okay, it has not taken a lot of time. Maybe it will stay for 1 week. Even if you itch for 1 week, lichenification cannot be there. So lichenification is what I'm trying to tell you, that lichenification is not there. Somebody is asking why not C? Because of this lichenification, it indicates that this is a chronic problem. Chronic problem has to go in the favor of atopy. Acute things will never give you lichenification. It takes time to develop lichenification. So allergic contact dermatitis is an acute situation. That is why there is no lichenification. I hope you understand. Okay, so the answer is atopic dermatitis. Which of the following is a primary skin lesion? Crust is not a primary skin lesion. Atrophy is not a primary skin lesion. Purpura is a primary skin lesion. What is a primary skin lesion and what is a secondary skin lesion? Okay. So what is a primary skin lesion and the secondary skin lesion? Primary skin lesion basically means unaltered skin lesion. Okay. There was a skin lesion that was unaltered. That is your primary lesion. Secondary skin lesion, some alteration happened to the primary lesion and it became a secondary lesion. So that is altered lesion. Alright. Crust, how will crust happen? Either there was a vesicle over there or there was a bulla over there. That ultimately led to oozing. That led to crusting. So vesicle and bulla is the primary skin lesion and the crusting will become the secondary skin lesion. Okay. Same with atrophy. Atrophy is just a manifestation of some skin lesion that has resulted into atrophy. Okay. But purpura, petite, these are all primary skin lesions. Simple question. If you know it, you know the answer. Now, which of the following statement is false regarding scleroderma? What is scleroderma likha hua hai, but this is scleroderma. The dermis is 3 to 4 times thicker than normal. That is true. Okay, the dermis becomes very, very thick, as a result of which it starts pulling your epidermis down. It becomes so strong that it pulls the epidermis down. Alright. It can give erythema and powdery orange appearance also. It is associated with sclerodactyly and Raynaud's phenomena. That is also seen. The patient complains of Raynaud's phenomena. Okay. Sclerodactyly means the fingers, they become kind of pointy and very thin towards the end. Alright. Can occur in association with diabetes? It can. The answer over here is that it is not really that commonly seen with diabetes. Erythema can be seen, powdery orange appearance can be seen. This question actually is not a very correctly formed question, but just if I am telling you scleroderma, you try to understand what can be there. The dermis is definitely thick, this is true. Sclerodactyly is a feature, Raynaud's phenomena is a feature on exposure to cold. Okay, the epidermis gets pulled down. When you say scleroderma, you think of it can either be localized or it can be generalized. Localized is called as morphia and generalized is going to be involving the whole body. Again, that is going to be limited systemic sclerosis or generalized systemic sclerosis. Okay. So for now, we can take the answer as association with diabetes. Identify the pigmentation. See, over here the answer they have given is the sclerodactyly and Raynaud's phenomena. I think what the question wanted to ask was maybe true because there is going to be sclerodactyly and there is going to be Raynaud's phenomena. So the answer is given wrong. Yeah, that's what I'm saying. The thing is that it can happen with diabetes also. Yes, that is why there's some problem with the question. The question is not very correctly framed. Because all of these things can more or less happen. But if you have to mark something, you know that dermis is going to be thickened. Sclerodactyly is a feature. Raynaud's phenomena is a feature. So if you have to mark something, mark C. Okay. Identify the pigmentation abnormality as shown in the image. Okay. Now, what is this? This is a shoulder. That is the first thing. Second thing, there's going to be increased hair. There's hypertrichosis. Okay. And what is it? There is pigmentation. Sometimes you can even see acne. So what does it look like? It looks like Becker's nevus. Very easy. Mongolian spot is going to be where? It is lumbosacral and usually seen in a child, a small child. Nevus of Ota and nevus of Ito, very important. Ito can happen on the shoulder, Ota can happen on the face. Okay, congenital melanocytic nevus also does not look like that. This is a very, very characteristic picture of Becker's. Okay. What is the most common causative organism of Verruca vulgaris? Again, if you know it, you know it. It is HPV2. Verruca vulgaris is the common word. Okay. And the most common organism is HPV2. This is a question you just have to mug it up. If these questions come, they have to be done in seconds. What is cutis marmorata? It occurs due to. So what is cutis marmorata? This is basically marbling of the skin. Okay, so your veins, if suppose this is the hand, your veins just suddenly start getting visible like this. Why is it happening? It is happening due to exposure to cold. Somebody has mentioned D. I hope you are answering D for the last one, because cutis marmorata occurs due to exposure to cold. Okay, it is marbling of the skin which is happening because of exposure to cold. Varicella zoster virus remains dormant in. It remains dormant in the dorsal root ganglia. These are very, very one-word questions, nothing to explain. You have to smug it up. Varicella zoster. So what happens is, first primary, I have already told you that it is going to be a chicken pox or varicella, not varicella zoster. This is varicella. It becomes dormant in dorsal root ganglia, DRG. Okay. And then when the immunity goes down, it will give you a reinfection or reactivation. So the reactivation of infection is called as varicella zoster or herpes zoster. So zoster word only comes when there is reactivation, okay, and it stays dormant in the dorsal root ganglia. Simple. Next question. Okay, this is the same question, has been repeated. 15-year-old girl presents with itchy lesions on her arms as shown below. Family history of asthma. What was it? It was atopic dermatitis. I've already told you. Lichenification, think of chronic problem. Atopy is a chronic problem. Allergic dermatitis is an acute problem. Okay. Bindi leukoderma is caused by which chemical? Also, some things that you have to learn. There are 3-4 names of chemicals that you have to mug up and you have to know them. Monobenzyl ether of hydroquinone. It is seen in what? It is seen in chappals or plastic. Okay. PPD. It is seen in hair dye. Hair dye. Okay. And paratertiary butylphenol. That is seen in bindi. So all of these are basically reagents that can damage your melanocytes and they can cause leukoderma. What is leukoderma? It is chemically induced vitiligo sort of a situation. So you have chemically induced depigmentation. Okay. So if it is happening, if you have a picture of the foot, it is because of chappal, those strands are given, it is monobenzyl ether of hydroquinone. If they say hair dye was applied, it is PPD, it is a irritant in the hair dye, and paratertiary butylphenol, that is seen in bindi. Okay, simple. Alright. Okay, the most common triggering factor of the given condition. Okay. Understand, look at the picture. What do you think this is going to be? What is this? This is a very typical lesion. These are, what are these? If someone can answer. These are target lesions. Okay. When I say a target lesion, they are going to have 3, this is a proper target lesion, they are going to have 3 zones. First is the central zone, this one, that is erythematous, hyperpigmentation. Then there is a zone of no erythema, and then again there is a third zone of erythema, which is comparatively paler than the central one. So this is the target lesion. What is the condition? The condition is erythema multiforme. Okay. Now, most common triggering factor. The most common triggering factor is actually infections. It can happen because of drugs. But infections, that too a viral infection, it is the most common triggering factor for erythema multiforme. Someone's answered drugs, no. The most common triggering factor, most common trigger are viral infections for erythema multiforme. Okay. A young female presented with, if you have any questions you can ask, okay. Alright. So, next question. A young female presented with vaginal itching and green frothy genital discharge. A strawberry vagina seen on examination. Strawberry vagina. What is the, you have to just know the answer from strawberry vagina. However, there is vaginal itching also and there is green frothy discharge also. What is this? This is trichomoniasis. Alright, what is the drug of choice? It is a bacterial infection. Let's rule out. Fluconazole is an antifungal, will not be used. Out of doxy, metro and azithro, metro is the drug of choice. Okay, simple. All of you kind of know it. Okay. What is correct regarding the diagnosis based on the given image? Again, we have seen this image before, we are seeing this image again. Look at it. ठीक है, red है, erythema है, but the presentation is dermatomal. I've told you what is it. I've explained you multiple times. This is herpes zoster because there is reactivation. Okay. So, there's a dermatomal distribution. This is herpes zoster. Now, they want to know what is correct regarding it. The lesions are not infectious. They are infectious. I've told you that someone who's not had chickenpox and they don't have immunity against this virus will get chickenpox because someone has herpes zoster. Okay. So, the lesions are infectious. This is not correct. Trigeminal dermatome is the most commonly affected dermatome. Okay. Anterior nerve root are more commonly involved. Okay. Mucous membranes within the affected dermatome are involved. Which of the following is correct? Anterior nerve root are not involved. I've told you that DRG is dorsal root ganglia. That is where, so not the anterior nerve root, the dorsal part is the one that is more commonly involved. Okay. So, lesions are not infectious, they are infectious, this is wrong. Anterior nerve root, dorsal root ganglia is going to be more commonly involved. Trigeminal dermatome, no. Usually, it is the thoracic region where the disease happens. So, even this is not correct. But mucous membranes within the affected dermatomes are involved, that is true. It can affect your mucous membranes. Okay. How I told you ophthalmicus can be there. So, that is a mucous membrane. Conjunctiva is involved. Okay. Somebody has said B, no. Trigeminal dermatome is not the most common dermatome. It most commonly happens on the trunk. Okay. So, that is not correct. But mucous membranes will be affected. They are not spared. Chalo. Next question. Now, what is the diagnosis seen on the image below? Okay. We have seen staphylococcal scalded skin syndrome. We have just seen there was a child. They had given a pharyngeal infection ka history. Okay. So, this is not staphylococcal scalded skin syndrome. What is this area? This is your toe. This is what? Intertriginous area. Okay. And this is the involvement. Okay. Now, so staphylococcal scalded skin syndrome is ruled out. It is going to be a child which is going to have skin peeling. So, that is not what it is. Candidal paronychia. What is paronychia? It is a nail infection. So, at least the picture will have a nail. There is no nail over here, not paronychia. It is an intertriginous area. Candidal intertrigo is the answer. Diabetic foot ulcer. It will be at the pressure points. Okay. So, maybe a heel or the ball of your great toe, they are going to be involved. Pressure areas. Okay. So, this is a candidal intertrigo. Paronychia, no. Please, somebody has answered paronychia. It is not paronychia. Paronychia, they will show you a nail picture. Okay. And around the nail, there is going to be erythema and there is going to be all signs of inflammation. Okay. Which of the following is commonly associated with the condition shown below? Firstly, you need to know what is this. This is a well circumscribed, loss of hair is there in a well circumscribed patch. What does it look like? It looks like alopecia areata. Okay, alopecia areata. Yeah, this is all for NEET also, and this is for FMG also. Questions are equally important for both. Okay, topics are also very important. Somebody has asked if this is for NEET. Yes, it is. So, which of the following is commonly associated with the condition shown below? This is alopecia areata. Oil drop sign is seen in nail of psoriasis. Okay. Leukonychia is just white lines. Pterigem of nail is seen in lichen planus. Pitting of nails is seen in alopecia areata. So, what is the answer? It is pitting of nails. Okay. Remember, pitting of nails can be two types. There can be RIDL pattern or there can be regular pitting. Okay. RIDL pattern is very, very important. Please you remember, a lot of questions can be asked if you just know these. Okay. So, RIDL pattern is random, irregular, deep, okay, and longitudinal pits. If this is the such situation, then it is going to be psoriasis. But if these are regular pitting matlab there is a pattern the pits are following like this. On your nail the pits are following a pattern. Then it is seen in alopecia. Okay, if RIDL pattern, you think of psoriasis. If there is regular, so this is random and irregular pitting, and these are deep pits. If there are regular pitting, that is seen in alopecia. So pitting is seen in alopecia. Okay. Yeah, regular pitting of nails. Okay. Chalo. Identify the condition given below. What is it? What does it look like? It looks like dark. It looks velvety. I've already told you the situation before also. This is what? This is a flexure. Flexure. Okay. What is this? This is acanthosis. Acanthosis, you will mostly either get an image of underarms or you will get an image of the neck, which have this dark velvety appearance. That is acanthosis nigricans. So identify the condition, should take you seconds. Acanthosis nigricans, move on. Okay, melasma will be on the face. Dermatomyositis, completely different, not even like a close DD. Alright, move on. Identify the drug used to treat the condition shown below. Okay. Alright, so what is this? This is kind of an annular lesion. Now, try to understand. If you see an annular lesion in the exam, okay, look at the center and look at the periphery. So, look at the center and look at the periphery. If the center is clear and periphery has activity, it is tinea. Okay. If the center has scarring and the periphery has activity, it is lupus. And if the center has crusting and the periphery has activity, that is leishmaniasis. Okay. Leishmaniasis they might not ask you, but these two are very important. So you remember, for your exam, you remember there is clear center or there is scarring in the center. Scarring. Okay. Now here you see there is activity in the periphery, but the center has scarring. Look at the scarring in the center. What does it look like? It looks like a wolf bite, like something bit us. So that is lupus. Lupus is like a wolf bite. Okay. What is lupus? It is basically a cutaneous manifestation of TB, lupus vulgaris. Is a cutaneous manifestation. Somebody has an antifungal. No, you guys, this is not a, again I've told you, why is it not tinea? Because center is not clear, there's a scarring in the center, okay? So that is why it is not tinea, so antifungal is not the answer. It is lupus, which is cutaneous manifestation of TB, it is anti-tubercular therapy. Alright, I hope you understand that why is it not antifungal therapy and why is it anti-tubercular therapy. If you have any questions, you can ask me. Alright. Topical steroids are not used. Leprosy is not going to look like this. How will leprosy be? Leprosy will be a hypopigmented patch. And mostly it's going to be an anesthetic patch. Okay. But if you have activity in the periphery and you have scarring in the center, it is lupus. The treatment is tubercular, anti-tubercular drugs. Identify the finding associated with the condition shown in the image. Okay. What is this? Okay, now let's look at the image clearly. It looks like something going in a linearity, and it looks like the lesion is similar here, the lesion is similar here, the lesion is similar here. Okay. So same lesion has spread. What does it does it ring a bell? Okay. Similar lesion has spread because of mainly itching. What is it? It is an isomorphic phenomena. Iso is same. Morphic is morphology. So, same morphology. That is an isomorphic phenomena. The answer is A. Gottram's papules you will see on the knuckles. Okay. Nikolsky sign is basically, it will come later, it is seen in bullous disorders, but that is separating of the skin, not seen over here. This is an isomorphic phenomena because same morphology has keep on, just kind of it's spreading like that. What is the other name of isomorphic phenomena? That is called as Cobner's. Okay. Yes, somebody has answered Cobner's. So it is Cobner's. Isomorphic. Remember, Cobner's you might remember, but you might not remember isomorphic. That is why I paid more importance to that. Iso is same, morphology, that is spreading, so it is an isomorphic phenomena. Next question, identify the condition shown in the image below. Okay. We have seen molluscum contagiosum. It does not look like that. What is it? It is pearly and umbilicated. Two things you should be confused, that is acceptable, is impetigo and herpes labialis. Okay? Nothing else you should confuse in. Herpes labialis and impetigo, they can at your stage look a little confusing and people have answered A and D. So, I understand. Let me tell you how to understand what is the right answer. In case of impetigo, the picture will be of a child. I am just telling you how you get to a right answer. Okay, in herpes labialis, mostly it is an adult picture. So look at the picture, it looks like an adult, does not look like a child. Here there is going to be crusting. Here they are going to be grouped vesicles. Okay. You see these vesicles over here, this. These are grouped vesicles. This is herpes labialis. I know images in dermatology can be a little confusing. Yes, that crusting is a honey colored crust. Somebody has answered that. Yes, I have already explained that to you. Honey colored, orangish brown crust. Okay, you get the gist. So if these are grouped vesicles, it is herpes. If there are mainly crusting, that is impetigo. This is herpes labialis. Next question. Which of the following drugs is used as a nail lacquer belongs to morpholines? It is so easy. What does it say? Morpholines. What rhymes with it? Emrolfine. Okay. So morpholines is emrolfine class of drug. Okay. You can either use emrolfine or you can use cycloperoxolamine. These are the two drugs that we are usually using as a nail lacquer in cases of fungal infection of the nails. Emrolfine you apply once a week, and cycloperoxolamine you basically apply it every day. The problem with cycloperoxolamine is that you have to apply it every day. It becomes difficult for the patient, okay? But once a week is okay. You tell the patient once a week you apply this nail paint and then remove it after 1 week. It's easy. So they prefer this better. All right, next question. So there's nothing to know, you have to just mug it up and you will know the answer. A child was born with membranes around the body and had ectropion. Okay. First of all, the very important is that he was born with membranes. Okay. If they say born with membranes, think of harlequin baby. This also looks like a harlequin baby. And he had ectropion. He was brought to the OPD with lesions covering his face, trunk, extremities. Okay. Which of the following is an unlikely diagnosis? See, if he was born with membranes, I have already told you that that is something like a harlequin baby. Okay. So this is harlequin baby. I think PDF will be available. I am not sure. Mostly I think it will be available. Okay. Coming back to the question, the child was born with membranes. He had ectropion. He was covered. His extremities are covered. What is unlikely? So harlequin ichthyosis, it is definitely. The other name for harlequin ichthyosis is lamellar ichthyosis, because there are huge lamellae that are covering the baby. Okay. And very similar thing is bathing suit ichthyosis. But when we say ichthyosis vulgaris, it is not this severe. Okay. So ichthyosis vulgaris in ichthyosis vulgaris, the patient will basically have very fine, basically have dry skin, you know, small scales, and it is not that severe. The child is not covered in a membrane. The child is usually born normal. On the extremities they have all the dryness. Okay, extremities are involved. That is ichthyosis vulgaris. So this child will not be, this is not ichthyosis vulgaris. This is a severe form of ichthyosis, which is a harlequin ichthyosis or a lamellar ichthyosis. Bathing suit ichthyosis, people have answered C. No. Bathing suit ichthyosis is also, bathing suit is like a big thing, you know. So it covers the entire trunk of the baby. That is also, so that baby can be born with membranes. If the entire trunk is covered, possibly they were born with membranes. But ichthyosis vulgaris, they were definitely not born with membranes. Okay. Alright. So let's go ahead. I think I'm covering what I have written, which is sorry on my part, but I hope you understand what I'm trying to tell you. Okay. Next question. A 10-year-old, so it is a child. Firstly, child hai, complains of mild painful swelling over the scalp for 3 months. There is a painful swelling on scalp. He also has a pet dog. Okay. Which of the following is a diagnosis? If you want to let go of so much information, you can just look at it. It is a scalp lesion. And what else is there? There is oozing, pus. Okay. What is it? It looks like a boggy swelling. Yes, it is a chirion. So 10-year-old male child comes with painful swelling over the scalp for 3 months. He has a pet dog. Now cheiron is a inflammatory. Tinea capitis. Okay, that is cheiron. And why have they given a pet dog situation? Because the tinea that you get from animals is an inflammatory type. Okay. Even if you don't know that pet dog gives you an inflammatory type of tinea, it is not required. You just look at it. It does not look like a furuncle. It does not look like an epidermoid cyst or folliculitis. What is folliculitis? A single hair follicle is involved. What is furuncle? That hair follicle is involved, but along with that, so single hair follicle is involved, but folliculitis, that hair follicle and the surrounding tissue, that will become a furuncle. Only hair follicle is folliculitis. Hair follicle with the surrounding tissue becomes a furuncle. This is definitely much bigger. It is on the scalp. There is a boggy swelling. There is oozing. It is cheiron. Okay. Next question. Now, a child with history of night blindness presented to you with the following findings. What is the diagnosis? There is night blindness. What does it say? It says vitamin A deficiency. What is the other? Let go of the picture. It says night blindness, vitamin A deficiency. How else does it come on the body? It comes in the form of phrenoderma. Okay. So even if you don't understand that this is a picture of phrenoderma, not needed. Let go of the picture. It is there to confuse you. Night blindness, vitamin A deficiency, other manifestation is phrenoderma. Could have been keratosis pilaris. There is, it can come on the elbows, but it will also present on the back of the, forearms. And keratosis pilaris will have absolutely nothing to do with night blindness. Okay? A very simple question. Phrenoderma, yeah, people have answered. A 30-year-old presented with a flaccid bulla. It's an adult with a flaccid bulla on her skin, which are easy to rupture. Okay. So flaccid bulla that are easy to rupture. The biopsy reveals a suprabasal split. What is the most likely diagnosis? Alright. See, this is your skin, has mainly 4, on palms and soles 5 layers, but mainly 4 layers. Stratum corneum, granulosum, spinosum, basalis. Corneum, granulosum, spinosum, basalis. Now either you can have a subcorneal split or you can have a I hope this is visible, a suprabasal split. Okay? Yeah, it's visible. Okay. So subcorneal split and suprabasal split. Okay. Now, there are 2 diseases, pemphigus foliaceus and pemphigus vulgaris. How I have remembered it is, this is on top and they are associated with anti-DSG antibodies. So, DSG1 and DSG3. So, 1 will come up. So, this is DSG1. 3 will come down. So, this is DSG3. F stands for first. So, this is pemphigus foliaceus and this is pemphigus vulgaris. I'll just remove this. This is how I remember this table. Okay. So, subcorneal or suprabasal split. Foliaceus is first. So, foliaceus is up. That is a subcorneal. And pemphigus vulgaris is going to be a suprabasal. DSG1, DSG3, 1 is first. So, it will go up. So, pemphigus foliaceus is associated with DSG1 and pemphigus vulgaris is associated with DSG3. Now, they are clearly asking you for a suprabasal split. What is it going to be? Pemphigus vulgaris. Simple. Okay. Just an easier way to remember if you can. If you remember it by some other mechanism, that's your call. Okay. Next. The treatment of choice for a patient with paronychia. So, there is paronychia of the index finger of the right hand. Okay. Simple. Paronychia is what? It is an infection of the nail. It can include the nail bed and it can also include the cuticles. What is the most common drug that we give nowadays is amoxiclav. Paronychia can be bacterial and it can be fungal also. Okay. Depending on the picture, if you see, bacterial is acute and fungal is chronic. Okay? And bacterial acute, you have to give antibiotics. Fungal chronic, you have to give antifungals. Acute infection, which is a bacterial infection, will have more signs of inflammation. Rubor, calor, dalor, all of them will be more in bacterial and they will be less in fungal. Okay, because it's a chronic infection, there is no redness now, there is no inflammation that much. But if it is a bacterial infection and they ask you for a drug of choice, the drug of choice is amoxiclav. That is what we prefer these days. Okay. Alright, a patient is taking multi-drug therapy, presents with worsening of existing lesion. So he is on a MDT. When you see MDT, you think of leprosy. Okay, presents with worsening of the existing lesions and nerve involvement. What will be the next best step? Okay, you need to know leprosy to know this answer. MDT the patient has been taking. He is a patient of leprosy. There is worsening of the existing lesions also, and now there is nerve involvement. What does it look like? If you guys have read leprosy, I hope you have because your exam is near. This is a lepra reaction. Lepra reaction are type 1 and type 2 lepra reaction. Generally type 1 and there is type 2. Okay? Type 1 lepra reaction may you have problem with the existing lesions and nerves are involved. So type 1 reaction is an upgrading reaction. The patient is getting better. Immunity was not there earlier, but it has started developing now. So now the patient has immunity. That immunity will act against the bacteria that is there in the body. As a result of which it will show signs. It is a problematic thing for the patient. But it is a good thing actually. If you look at it, the immunity is coming back. So you want to continue the treatment. So stop MDT, so out. You don't want to stop MDT. Now the patient is getting better. Now they are developing their immunity. It is a good thing. You have to continue MDT. Start systemic steroids, start thalidomide. This is a type 1 reaction, and for type 1 reaction we give systemic steroids. Okay. So let me just erase all of this and tell you that the answer is continue MDT and start systemic steroids. Alright, any question, just let me know. Why will you not start thalidomide? Thalidomide is not used for type 1 reaction. No. Why do I say that it is a type 1 reaction? The existing lesions are involved, they are becoming worse, there is nerve involvement and the immunity is developing, so the patient is facing a problem. If it was a type 2 reaction, it is a downgrading reaction. The patient is very happy in type 2 reaction. He thinks everything is fine, but that is not actually fine. Okay, so because it's going up, it is going towards the TT pole. That is why your lesions increase. Okay, chalo, next. A 30-year-old male patient presents to you with inflammatory alopecia. Okay. Which of the following variants of tinea capitis infection results in this type of alopecia? Alright. So, tinea capitis. It causes two types of alopecia. It is an inflammatory and non-inflammatory. Inflammatory are what? There is chirion and there is flavus. Okay. Non-inflammatory is grey patch and black dot. Grey patch and black dot are also called as ectothrix or endothrix. Okay. But inflammatory is chirion and flavus. Endothrix is not inflammatory, ecto-endo is not inflammatory, chirion flavus is inflammatory. Again, endothrix is not inflammatory. Grey patch and black dot. What is a grey patch and what is black dot? Black dot is called as endothrix and grey patch is called as ectothrix. Okay. Alright. Next question. A patient presents to you with multiple anogenital warts. The biopsy of these lesions show squamous atypia. Okay, matlab we are going towards cancer now. Which of the following human papilloma virus are considered high risk? Again, the top question in the picture is useless. The question is just this. Following human papillomavirus considered as a high risk? You know that it is 16 and 18, HPV 18. Okay, simple answer. Has somebody answered a C for, okay, C last year? Yeah, this is a B, okay. HPV 16 and 18 are high risk HPVs, simple. A farmer presents to you with swelling on the foot. So there is swelling on the foot, okay. And there are multiple discharging sinuses in the lower limb, alright. There are granules. From the discharge were examined under microscope, which was shown below. Which of the following is true regarding this condition? You will look at this picture and you will be like, this is not possible, I'll not be able to do it. You don't need to do it, okay. Don't look at the picture, let the picture go. The farmer comes with swelling on the foot and multiple discharging sinuses. What does it look like? It is mycetoma. Itna to you understand that this is mycetoma. Okay? There is swelling on the foot, there are discharging sinuses. Okay. Granules are also there, again mycetoma. Which of the following is true regarding mycetoma? Both bacteria and fungus can, yeah, it can be. Both bacteria and fungus can cause mycetoma. Bacteria causes actinomycetoma and fungus causes eumycetoma. Okay? Actino and eumycetoma. Done. Move ahead. But I will discuss everything, but you need to just go. So, mycetoma, actinomycetoma, eumycetoma, true. It undergoes lymphatic spread. There is a lymphocyte accumulation. It involves only superficial tissue. These are all false. It involves deeper tissues. It involves the entire limb will be involved. Okay, it does not undergo lymphatic spread. When you think of lymphatic spread, think of diseases like chromoblastomycosis. Okay, sporotrichosis. These are the ones that will undergo lymphatic spread, not mycetoma. Okay. A farmer presents to you with a cauliflower shaped mass on the foot, which develops after a minor injury. Microscopy shows copper penny bodies. Copper penny bodies, you should just know the answer. It is chromoblastomycosis. Copper penny C is seen in C, chromoblastomycosis. Okay? Sporotrichosis will have what? It will have asteroid bodies. These are star-shaped bodies like this. Copper penny bodies, medlar bodies, these are all seen in chromoblastomycosis. One word answers. Okay? Next question. A patient presents with an anesthetic patch. Okay. In the area, basically they want to say the face as shown in the image below. Which of the following nerve is most commonly involved in this condition? Let go of everything. There is an anesthetic patch, which I have told you is most likely leprosy. If in dermatology, if you have a dermatological picture and they say anesthetic patch, think of leprosy. Okay, so the patient has leprosy. The whole almost face is involved. What is it? It is facial nerve. Optic nerve, eye will be involved. Okay, anesthetic patch, facial nerve on the face. It is a sensory nerve. Alright? Facial nerve, everybody has answered facial nerve, good. A female patient with a BMI of which is very high presents to you with a lesion on the neck. So you know that acanthosis is very much a favorite of the examiner. Okay, so you have to be good with these topics that are being asked again and again. So she has a high BMI, she comes with a lesion on the neck. Which of the following condition is she suffering from? What is this? Again, this is acanthosis. Nigricans. Okay. What is acanthosis nigricans associated with? It is associated with diabetes, obesity, PCOS. Out of all of these, hypothyroidism? No. Hypothyroidism are even thin people. No, hypothyroidism are fat people, sorry. Hyperthyroidism are thin people, but does not come with acanthosis. Metabolic syndrome? Yes. Metabolic syndrome is associated with diabetes. There is obesity, okay? Acanthosis nigricans, all of these are features of the same problem. Acanthosis nigricans, PCOD, obesity, yes, all of you have answered the question, good. Now, irregular pits. Irregular pitting, I have already told you about pitting, okay? I told you that there is a RIDL pattern and there is a regular pattern. The regular pitting is seen in alopecia areata. RIDL pattern is seen in random irregular. Irregular is the question. It is seen in psoriasis. So with subungual hyperkeratosis is seen in psoriasis. Okay? Simple. Just remember pitting RIDL. At your level, you just need to know RIDL and regular. Regular is alopecia, RIDL is psoriasis. Alright. Now, a 35-year-old woman presents to you with hair loss. There is a hair loss. For the past 3 months, okay, she tested positive for COVID-19 8 months ago. What is the likely diagnosis? Okay. So, she had COVID-19 8 months back and she's been losing hair for the last 3 months. So, she started losing hair 5 months from the problem. Okay. If you look at the picture, there is diffuse thinning. There is a little bit of hair loss here. I can see scalp here, 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 here. There is not a pattern that is being followed. So, I cannot call it a male pattern or a female pattern hair loss. That is not the situation. There is diffuse thinning of hair which happened after, an episode of illness. What is it? It is telogen effluvium. Okay. Why is it not trichotillomania? Trichotillomania happens when the patient starts pulling their hair themselves. So, usually on the dominant, suppose the right hand is dominant, so on the right side you will see broken hair. You will also see, blood clots and broken hair will be present. So, that is why it is not trichotillomania. Tinea capitis, 35-year-old, very unlikely to have tinea capitis. Tinea capitis patient will be a young child. Okay. Telogen effluvium, why? Because there was COVID-19. The history of COVID-19, which is an acute illness, after which the patient started losing hair. That is telogen effluvium because of stress. Okay. Chalo, next question. A lady developed a skin reaction as shown in the image after using a hair dye. Which of the following chemicals is, I have told you. We have already discussed 3 chemicals, out of which pollen, chromates, balsam of Peru is not the answer. PPD is present in hair dye. Okay. You need to know bindi, you need to know chappals or plastics, and you need to know hair dye. Just these 3 chemicals you need to know. Hair dye is PPD. Okay? Chalo, next question. A female presented with acne that is not resolving. So, there is acne. She's been given oral isotretinoin and it is not getting better, and antibiotics therapy. Which of the following is the next best investigation? Okay. So, it is a female patient. She has acne that is not resolving. What do you think of? Think of PCOS. Okay. Female with acne, think of PCOS most commonly. Look for dietary triggers. Which is the next best investigation? Dietary triggers, okay. Evaluate for hyperandrogenism. Yes, you want to evaluate if she has PCOS or not. You have to evaluate for hyperandrogenism. Check for antibiotic resistance. No. Look for drug triggers. No. She has PCOS. Evaluate her for hyperandrogenism. Okay. Next question. A young woman presents with complaints. So, it's a young woman with a painless ulcer in the genital area. It is associated with non-tender inguinal lymphadenopathy, which is non-tender. So, ulcer is painless and lymphadenopathy is painless. What is the most likely diagnosis? You need to remember, if both the things are painless, it is syphilis. Chancroid, it is painful. Okay. So, if it is a painless ulcer with a painless non-tender lymphadenopathy, the answer is syphilis. Okay. Yes, everybody has answered syphilis. Syphilis is good. Okay. Which of the following is associated with the clinical condition shown in the image? Okay. Cataract, glaucoma, malignant melanoma, PCC. What is it? Is it not a very big nevus? If it is a very big nevus, the nevuses have, big nevuses, they have a tendency to get converted into a malignant melanoma. Okay. So that is why if the clinical condition shown in the image, what can be the association with the nevus like this? It could be malignant melanoma. Everybody knows the answer. Great. All right. I think this was the last question. Yes. So a 1 hour 40-minute session. This is not a pre-recorded session. I am answering everything that I am seeing here. So it is a live session, and so this was dermatology. See, try to understand that the questions are not as important as the topics are. Make sure you revise these topics. Make sure while you're here, you just jot down these topics, okay, and you revise them last minute. One more thing, dermatology is a very easy subject. Don't take stress about it. Just make sure that you look at the images very, very clearly. And once you look at the image, sometimes you don't even have to read the questions. You just have to look at the image and mark the answer. Sometimes the image are made very, very difficult so that you get confused. Ignore the image, read the question. The question will give you a clue for the answer. Okay? That's it. All the best, people. I hope everybody who's worked hard for it gets the result they deserve or they are working for. All the very best. Thank you. I think the PDF link will be provided. I'm not sure, but we will try to get it provided. Thank you. All right.